Welcome to Crash Cart Nursing, where we help resuscitate your nursing education one topic at a time. Hey, everybody, welcome to Crash Cart Nursing. My name is Nick McAllister. I'm an ER nurse turned nurse educator. And today I've got Courtney Wong with me. We're going to be talking about all kinds of fundamentals through stories, experiences, talking about some mistakes that we've made as nurses and how we overcame those mistakes to become better nurses. We're going to give you some real world experiences. It's going to be a lot of fun. I hope you enjoy.
Let's see. I've been a nurse since 2019. I'm actually from Florida, so I ended up graduating from nursing school in Florida. Started out in long-term care, moved to ortho trauma, ended up switching to ICU nursing, and that's kind of been like my specialty for the last couple years. My husband Ernesto is actually a nurse, so we ended up travel nursing. Came to Idaho, loved it, thought the people were really rad. So we ended up staying here. Currently, I do work virtual nursing too, but I am also a new nursing educator, so really exciting. I've kind of built this really good feeling about teaching, and I get a lot of fulfillment out of it. So we're starting to go that way.
Yeah, it's super awesome.
Yeah, it is. It is. I've honestly, as cheesy as this sound, I've never felt like this much professional fulfillment. So it's been really cool. It's been really cool. So we're going to start kind of going more the nursing education route now.
Yeah, that's rad. What kind of nursing does Ernesto do?
He's a med surg nurse. So, well, actually, his background med surg. That's what he's kind of done for the past, the first 6 years of his nursing career. That's what he did. He actually works at the same virtual spot that I work at now.
Rad.
Yeah, because it's a super easy job, super chill job. It's called hospital at home. So we, provide bedside nursing to people in their home. We work through like 5 different programs throughout the entire day. I work on a monitor that's literally like 4 freaking feet long, and I have 2 of them. So,
Oh my God.
yeah, we're basically nursing coordinators. So we're the brains, and then we have people who we send out to the home that are like our hands, right?
Is that weird to be helping people virtually and not be hands on with them? I mean, especially coming from like the ICU and
So i- it's definitely been a transition, yes, coming from the ICU. The whole like virtual aspect kind of wore off being weird pretty early on into like doing that. Especially because like we still call in, we still, do our assessments. Just the difference is we're not the ones actually putting like our stethoscopes on them,
yeah.
right? So it's the same nursing, but it's nursing that now we're kind of taking these skills that we've really built up the last couple years, and we're morphing it into being able to ask the patients questions for like, instead of physically assessing, how can we ask them?
Do you feel like that those patients are then able to better identify their own symptoms after that? Because I feel like it'd be like a different teaching methodology with those kind of patients. Like, maybe like I don't know. I feel like a lot of patients are really not super self aware. And so like when we teach them like what to look for and like can you do this? Like do you feel like are they better equipped after?
I, in a way, yes. There there's a whole nother education aspect that comes with this. Um, the good thing is that 9 times out of 10, our patients are pretty independent, right? And so asking them, like if we're wanting to look at, say, the edema in their legs, usually we can kind of walk them through like, applying pressure so we can see if it's pitting and they can take pictures. We can also do that, face to face, kind of like you and I are now. Um, and so in a way, yes, it is a little bit more difficult. But if the patient can't do it, right, we don't send someone home who doesn't have a way to like take care of themselves. So if they
Sure.
don't, there's usually like a caregiver or family or someone like that.
Yeah,
So
I'm sure the
it
criteria is pretty strict of who can be at home by themselves as a hospital at home patient.
it is the first of its kind in Idaho. Actually, a little bit of a superstar in the hospital at home kind of environment
Oh
because I
yeah.
took the first patient. Yeah.
Oh dang.
So like we're still kind of finding things that work, things that don't work, right? We went live November 5th of 2024. So we're still very, very new. So th- there is criteria and there was like set criteria, but then, some things don't work and some things do work. So we're finding all of these little loopholes as we go along.
Yeah. I just wonder how long it'll be before we have a AI robot at home doing all your assessment for you and probably all of the things, and you and I no longer have a job. I hope
you
not.
know,
I don't know. I don't really want an AI bot hanging out at my
yeah.
house, you know.
Well, we won't have jobs and we won't have clean drinking water. So it's really a lose-lose situation if AI gets that big.
No doubt. Well, Courtney, it's awesome to have you join the podcast.
Yeah,
You
thanks for
know,
having
the goal here is to build Crash Cart Nursing into this awesome experience where we talk about the everyday aspects of nursing, but also kind of connecting classroom learning to real practice. We're going to be doing some different supplemental education things, not just lecture, but really kind of bringing nursing to life. I feel like storytelling is such a huge part. I had
Yes.
instructors when I was in nursing school that were awesome about telling stories, and I had other ones who I swear never told a real life story. And I'm like, are you really a nurse? For me, I like to show the things that I've gone through as a nurse, and students are so curious about those things and they really, really absorb that. And I feel like it connects us to them and it connects them to nursing, and that's a really, really cool thing to be at, because through that we demystify the nursing profession. And so it doesn't feel like this just really out there concepts. It's like, hey, this is how this applies to real life. So I guess kind of the plan here, the hope is that, you know, nursing school teaches you the science of nursing, the job teaches you the art, and hopefully this podcast kind of just makes all of that come to life and have to where you have a good time with it. Because nursing school is stressful, and like I always tell my students, you can do hard things. This is a hard thing to go through.
Yeah,
So
it sure
whether you
is.
have already joined the nursing profession, you are currently a nurse, I think that there will be stuff that we add value to your career. But if you're a nursing student, we want to add value to your education. And the whole thing is we're helping you resuscitate your nursing education one podcast at a time, because let's face it, sometimes we can't get through all the content. I lecture and I can talk for days about nursing and
Yes.
still not get through everything. There's just too much
Me
stuff out
too.
there. And you can watch a whole bunch of different YouTube videos, and you can watch a whole bunch of different things out there on social media. And those are all awesome. But you got to find the thing that's going to help you. So I hope that this podcast is going to be something that helps you dig deeper into nursing and find joy in nursing.
Yeah. And just to kind of add to that, for me, it's also really hard to know what is a reliable source too. So I'm really glad that we're kind of providing this, source that they can use, that they can trust. That's what I
Yes,
want, is for you guys to be able to trust what you're learning and what you're hearing.
absolutely. And like, that was one of the things that was so hard, like when I first got into education, because you'll hear people say, well, this is real world and this is NCLEX world. But those two have to coexist, right?
Mhm.
So to be trustable, we got to be able to know, what does the book say to do? What happens in reality? And why is there a disparity between? Sometimes it's because of inopportune staffing. Sometimes it's because of bureaucracy in a hospital. Sometimes it's because of policies, procedures, things that got modified. I have experience of helping write policies and procedures, and it is actually totally possible to screw yourself over as an organization when you
Yeah, it
write
is.
them, because you can write policies that are more stringent than standard of practice, and vice versa. So you can write them way too lax, and then people kind of just do whatever they want, or you can write them too strict, and then you're putting yourself into a corner of like, oh, we have to do
Right.
100 steps for one thing, and it's
Yeah,
too
like, this
much.
looks
And
really good
then
on
you end up
paper.
getting screwed over by your accrediting body. So it's always a challenge. But I think, yeah, we want to be that reputable source that tells you the right way to do things, knowing that things change and things evolve. So like if you're watching an episode and you're like, that doesn't seem like best practice, like for sure, send us a message, like let us know, because Things are always evolving in healthcare, and that would probably be something really fun to talk about in an episode, of things that were one way when we started that are now a different way, and trying to future predict what is going to be the standard of care tomorrow is really hard, because who knows?
So we're going to kind of start this episode off with talking about this idea of fundamentals being advanced skills, right? Which sounds kind of silly. You think that these things you're learning like in your first term or your second term, right? They seem very, very easy, but these are actually the skills that when you are assessing your patient, right? And you're doing your 6 rights of medication administration and you're documenting, these are skills where if you make a mistake, this is where it's going to happen, right? Normally people aren't making mistakes on these really, really advanced skills because we're aware that they're advanced, and we don't take that for granted, right? And I've kind of tell people that, like, right, when I'm teaching the class and we're going over the full head to toe assessment, one of the things that I really encourage you to do is learn how to do an accurate, thorough assessment. Because sometimes that's the difference of like you finding things, right? And you not finding things.
It's interesting because a head to toe assessment seems like a really basic skill, and it is a basic skill. And the best way to really make your assessment great is to get so comfortable with what does normal look like. Because once you know what normal looks like, abnormal sticks out like a sore
Mm-hmm.
thumb. But I think sometimes, especially when you're new, it feels like you have to ask every single little question. And so much of assessment is observation, right? So much of assessment is, I hear what you're saying, right? That is the subjective data, but I see what is actually happening in front of me, and that is our objective data. And it's so important to be able to have that across the room assessment, have that ability to see beyond what the patient is telling you, or as I like to call it, the bullshit-o-meter, because
Shitometer.
people lie about all kinds of different things,
All kinds of different things.
all kinds of different things. In the ER, one of my favorites is always the, how did that get up there? Well, I tripped and I fell. Well, you're a liar.
You need to go buy a lotto ticket because that's like a 1 in a million opportunity, my guy.
It's amazing how they all tripped and fell on these phallic objects in the shower.
Or flashlights too. That's another popular one, but
anything is a sex toy if you're brave enough. I really think that we should create a business where we make a Attach-A-Flare that has some kind of like 2-part epoxy resin or something, to where it's like unbreakable. It holds on forever. Like Gorilla Glue, please sponsor me on this. Let's make this a patented thing. Attach a flare, flared base to everything. You can turn any household item into a safe, ER safe sex toy.
There you go. Coming soon to Crash Cart Nursing. Stay tuned. Add a flared base.
Build a flare. It'll be like build a
flare. Oh my God.
It's going to be amazing.
It's going to be really amazing. Oh my God. Kind of circling back of what normal looks like. Because I feel like a lot of the times when students have had, right? Like when people with experience, like we walk in and we look like all we're doing is listening to lungs and the heart, right? But in reality, that's not true. Because as you start to get really comfortable, right, with assessing like orientation, something as simple as orientation, right? You start to get to where like I go in and I just talk to my patients, right? There's a lot you can tell. So it may look different from what we're teaching you, right? Because we go in and we teach you like step 1, ask if they know their first and last name, which you should always do. Disclaimer, that's not me saying that you don't ask your patients their first, last name, date of birth. But we might not go in, right, and ask, do you know exactly what day it is today? Do you know what you had for breakfast yesterday to assess orientation. So when you're looking at these more experienced nurses, they're doing the same exact thing you are. Just now they've crossed this boundary of being a novice, right? And now they're experienced. So this is something that even though you're not doing it the way that you learned it in nursing school, you are still completing all of these steps. So very, very important.
Exactly. Well, and the thing is that like, um, yeah, of course I'm going to ask their name, their birthday, all that stuff, but I may not go down a rigid line of questions. I'm just having a conversation, right? It's just so much of
Right.
that. Hey, let's just talk. And as I talk, I can tell, do you know what's going on? Because sometimes people are oriented to the situation, but they may not know the exact date, right? And
Right.
like, I have to look. I feel like a cheater all the time because I'm like, I got to look. What day is it?
Have it on my watch.
Yeah,
Yeah.
exactly. But part of being able to tell if somebody's alert and oriented too is, can they figure out what they don't remember? That's part of it. Is
Mhm.
so like, I don't know what day of the month it is, but I know that I can look to my phone. I know that I can look to, or I
The
don't know exactly
whiteboard
what
in
time
the
it is
room.
in the day, especially in the hospital, right? Sometimes you're in the hospital, it feels like Vegas. All the time feels like the same
Yeah.
time, unless you have a good window seat,
Yeah.
but if it's like a gloomy day, it might feel like it's 2 o'clock in the afternoon all the time. So they don't know. But if I have the clinical reasoning to be able to look up on at the clock, like that is telling me that they know, then they are more oriented than what I think. Because patients who are really out of it, they're not looking up at the clock.
Right.
They don't even have that reasoning. So I think that those are good skills. And I mean, how many times have we seen it though, where students are so rigid that they like think that they have to go through the checklist. They think that they have to go through every single little thing, which that's a great place to start. But
Mhm.
comfort comes when we get to that point to where we're like, okay, I know what's on the checklist. I need to ask the questions, or I'm going to observe these different things. But also charting at the bedside is so hugely helpful
So hugely helpful when you
and
get
really is a
started.
best practice
Mhm.
thing. So like this concept of like I'm going to go in and do all my stuff and then I'm going to leave. Well, what happens when you find out that there are 10 things you didn't ask? You got to go back in there. It's a pain for you, it's a pain for them. So we want to be efficient with our time, and that's part of time management that is so crucial. And that's such a huge fundamental skill, is being able to know, what do I need to do when I'm in the room? And
Right.
charting bedside helps with.
It does help with that, especially because one of the things I've noticed is that a lot of the time when you start to go and you start to orient, right? Some of the advice that I've seen being given is go get all of your stuff done and then sit down to chart. I am gonna encourage you not to do that
Amen.
because, if you have I mean, even in the hospital, when you have 5, 6 patients, can you imagine having 30 freaking patients? And you're going in and you're trying to remember room 12 had abnormal breath sounds, but are you sure? Because it very well could have been room 11.
Yeah.
It's even for the
Unless your
the
note
most
taking is
experienced.
impeccable, it's just not a recommended way of doing it.
Yeah, right. No, best practice, document by the bedside for sure.
Yeah, I love it. So currently I moonlight at the prison, and I don't really love working there from the standpoint of the documentation. And no, I'm not going to get fired for saying this, but I
Okay,
just
just don't say
they
the name.
know because I've said it to them. Like I love documenting in real time. I think that it is the
Mhm.
absolute best practice, and if you can do it, you should.
Yeah,
Obviously, there are different places where it doesn't make sense. So, like, it's not the safest for me to be at the bedside in a maximum security prison and documenting at the same time. And there's not really a functional way for me to do it. So, we do a lot of writing stuff down and go back and chart it. But it's each interaction, I'm back at my desk charting most of the time, unless I'm rounding on a
right.
bunch of people. That prison is a whole different world. And it's a cool world. It's an interesting world to work in. I wouldn't say it's cool. It's an interesting place to work. Definitely unique setting. But the thing is that the I really do value being able to just chart at the bedside, get all my thoughts down of what I'm thinking, and I don't just chart for my employer. I chart because I don't want to get subpoenaed. And like I got subpoenaed one
Yes.
time, and it's terrifying because I got subpoenaed, had to go all the way to the court, and they ended up settling like 5 minutes before I was supposed to go in. I still had not seen my documentation. To this day, I don't know exactly what I documented. And that was like my biggest thing was I'm like, did I document well enough? I knew that it was a patient who had had a DUI, and they were calling me. And I'm guessing, if I had to guess, it's from
Mhm.
a story of a guy that he ended up getting sent out AMA because he was being horribly rude to staff. And the doctor said, "You know what? I'm going to discharge you AMA. Like, we're not going to do this. You're treating everybody badly." He's like, "You can't discharge me." And he said, "Yeah, I can. You're medically cleared. You can leave." And he kicked him out of the ER. And I told him, I'm like, your blood alcohol level was like 400. I'm like, if you get in your car, I have to
Wow,
report you,
that's high.
and you're going to get a DUI. And so I made sure, if it's the one I'm thinking of, it could be different. I've charged so much and taken care of so many people over the years. I don't know if this was actually it or not, but I said, hey, if you do leave, I got to report you. Anyway, so fast forward 3 years later, I get subpoenaed for somebody and say, hey, you need to come testify in this DUI case. You're the nurse of record and have all this stuff on the chart. I'm like, well, can I see the chart? And they said, no, they'll show it to you the day of the court case. Well, there's really no way to prep for that. How
Yikes.
do I prep
No.
knowing what to say? I can't. I just have to go off of what my documentation is. It's not like you can say, well, I would have done this, or I should have done this, or like, you just have your chart. So in my
Mhm.
charts, I always write a good narrative note of, like, when I first assess the patient, I write a good narrative note of what is going on with this patient. And it's really not even for my employer. Like I said, it's all for me. It's for my own history, so that if I do get subpoenaed, I know exactly what happened because I wrote a great narrative.
Mhm. Yes, amen to that. Especially because, like, with my background being in the ICU, right? Well, people are so, like, medically complex that you have to write the narrative notes. You have to. Because if something like that happens, and I always use like, the saying of chart like the absolute, like, weaselly, skeeziest lawyer is gonna look through your charting
No doubt.
and try to find what you did wrong, right? So this is not only someone who's which, no, no shade to them. I mean, this is someone whose job it is to find inconsistencies and, like, pull them out and spin it in a way that looks bad. But if you, like, when you write that really objective narrative note that uh, is is ultimately going to protect you, 100%. I am also on board with that.
That's why you got to get good at making sure you're using approved acronyms. There is a whole list of approved acronyms and approved shortening of words. And sometimes people still pull out stuff that is not legal to use. CC is one that we see a lot.
Mhm.
CC is not an approved, per the NCLEX, it's not approved by any board of nursing that I know of for documentation, but we still
Yeah,
see
definitely
providers putting that
outdated.
in there. It's milliliters or ml, right? It's like
Mhm.
making sure that you have those correct things. So know those approved abbreviations and use those. You're not even supposed to put PT as the patient, because PT is a physical therapist, not a patient. So you're supposed to actually write out the word patient. There's
Mhm.
different things like that that are very nuanced, but we all have seen the different chart notes. It's like PT arrived, SOB, uh, W/CP, patient arrived with shortness of breath and chest pain, right?
Right.
Well, a lawyer could interpret that as patient arrived with son of a bitch and uh,
And oh,
cerebral palsy.
thank you. I couldn't think of an appropriate couldn't think of an appropriate way to think about that.
I'm just saying, but like, I've done it. I've written that way.
Yeah, for
But
sure.
obviously, if they're standard practice things, they're standard abbreviations, we do a lot better with our notes, and people can tell the whole picture of what's going on. And then when you can take a picture, put a picture on the chart. If it's a wound or
Yes,
whatever,
especially of your wounds, guys. Take pictures of your wounds, please.
yes, put them on the chart. Use it in the appropriate way. Don't put it on your cell phone. That's not legal.
Nope, put it on your work phone.
Put it on
Most
your
of the
work
time now
phone.
they have, like, the little apps too that are
Yeah,
kinda
the
cool that you
Volt
can.
the Volt phones are awesome for that.
Yeah.
It's like you can take your picture and it uploads straight into the chart, and it's never on your personal device.
Mhm.
Obviously, some places still do stuff like that. Just make sure you're going through the right protocols, because you don't want to have confidential information on your phone. You don't want to have somebody's patient
Yeah.
data on your phone. It just makes you look terrible, and it's not legal.
And honestly, just protect yourself, guys. No one's gonna protect you better than you do, so just make sure you're following policy with stuff like that. You see
I
it all the
so agree
time
with
when
your
people
point.
don't.
I so agree with your point that some of the most dangerous mistakes happen on most basic tasks.
Mhm.
It is the simple stuff. It's the stuff that those fundamental things that are routine. It's easy to just do stuff wrong. So you want to make sure you train good habits.
Yes. Amen to that.
I will never forget my first week as a nurse. I feel like there was so much trial by fire. Um, I don't know of any nurses that don't feel that way. That like that first week out, you're just like, oh my gosh, what if they asked me to do something in front of other people? I remember I was on the floor for about 30 minutes when with my preceptor, and we had this old lady fall. And I didn't have very many patients. I was working at a small critical access hospital on med surge, but I was nervous because when I went to nursing school, there was not really We didn't have simulation. We didn't have in-depth labs. We had some labs, but I had never actually. I'd poked one person throughout nursing school, and it was my first day. And this lady just biffs it. Go in there. She's got a giant head lack. Um, her
Laceration
she
for
ripped her
anyone not
yeah
familiar with
she
that.
ripped her IV out, so she's bleeding all over the floor, and she's laying there and she's saying, "Mama, come get me."
Oh, that's the
It
worst.
was terrible. Okay, first day, and my preceptor goes, well, um, we're gonna put her in a seat collar. We ended up getting a backboard, put her on the backboard, and he's like, "I'm gonna go call the provider. Will you start a new IV on her, because she had ripped her IV out?" And I'm like, "Oh God." First
Yeah.
day starting an IV, and I felt like such a noob. And like, it's different supplies than what I'm used to, right?
Mhm.
Because they had nicer stuff than what I was used to, but I didn't know those materials, right? So I kind of felt out of place, because I'm like, what the heck? What do I do? So I tried, I missed. I gave it a college effort, but it was kind of more like a middle school effort, because I didn't
Yeah.
know what the heck I was doing. So anyway, so I told him, and I told my preceptor, I'm like, hey, I tried, I missed. I'm like, I don't want to keep poking her. I don't feel super confident. And we had gone to the same school, so he knew it was up. He's like, okay, no problem. So he comes in there and shows me how to do it. And I feel like it is so important to make sure that your preceptor knows and understands what your skills are and what they are not, and be real about it, because everybody has been there as a new grad, knowing that not everything is ideal coming out of nursing school, right? You go to nursing school so that you can learn enough to take the NCLEX. You do not go to nursing school to be a seasoned nurse. That comes with time. So
Right.
he was really cool about it and showed me some different tips and tricks. And then we had an ER nurse on that night too, who was amazing. Her name was Hannah, and Hannah walked me through and took me through a bunch of stuff. She taught me how to float an IV. She taught me how to do all kinds of different stuff. And within a couple of days, I felt so much better. And I had
Well,
had
that's
a
awesome.
million more experiences of doing this. So I feel like just really what I learned the hard way here was don't think that you have to know everything right out of nursing school. It is totally normal to feel like ultra noob. You're like, do I even belong here? And that imposter syndrome is pretty strong, of like, oh gosh, maybe I did the wrong thing. Maybe I went the wrong career path
Mhm.
here. But really, it's just inexperience talking is why you feel that.
Right. And I mean, honestly, I don't know if this kind of affects you like it does me, but sometimes I still get imposter syndrome. Like
No
even
doubt.
just kind of transitioning into the educator role, I'm kind of like, wow, like I'm the adult nurse here, you know?
Yeah.
Um, but no, like no one ever expects you to know anything. That is why, coincidentally, it's very important to ask questions. Um, but things happen, right? I remember when I first started, and this was in the long-term care, which honestly was already kind of an experience because, like, I did go through straight for my RN, and so, um, I have a lot of respect for LPNs because, like, the beginning of my nursing career, right, that's who supported me, and that's who talked, mentored me and taught me a lot, and so I do remember one time, though, there was one other RN there, she was not very nice. Am I gonna name drop her? Nadine.
You do what you want.
I am gonna name drop you, Nadine. Mhm. Mhm. I remember you. Um, so when I first Lantus pens were, like, not really a thing, right? When I went to nursing school, like, they were kind of there, but they were, um, a little it's so funny because it sounds like back in my day. Anyway,
Maybe it was your
um,
facility because I think Lantis pens have been out for a long time. You might have
yeah,
just
and
been in the ghetto.
yeah, I was. Yeah, I was. And so, like, I really didn't have a lot of experience with it, right? What I had experience with was, like, you had just a bunch of the insulins in your cart, and you drew them up and gave them to the patient. And so I remember the first time I used a Lantus pen, I was like, "Hey, I don't really know how to do this." And it was a brand new pen, right? Sealed, all the good things. Um, and so I opened it, and she showed me, how to take off the little paper on the needle and put it on there and screw it on, and how to prime it, right? She's like, you always prime it with two. She didn't say it quite that nice, but she was like, you always prime it with two. And I gave the patient their, I don't even know, it was not that much Lantus, and I threw the freaking pen away.
That's awesome. Have you
A brand,
since looked up how expensive a Lantis pen is?
so Nadine told me how expensive latest pens were. Not, and I just remember her, like, I went and I don't even remember what she was doing. She was not by the cart. I don't know why you're letting me give this for the first time by myself. Um, but I went and, like, I tossed it in, of course, the sharps container, right? So it's not like you can retrieve
You're not
it.
retrieving it.
Yeah. And she's like, where's the Lantus pen? And I was like, I tossed it. And she goes, yeah, so those are multi-use. And I was like, oh, sorry.
You're like, thank you, Nadine. Thank
Thank you,
you.
Nadine. I will remember that. I mean, I definitely wanted to crawl under a rock when that happened, but it's fine.
It's so funny because like I feel like that there is so many stories like that where a just your preceptor can just look at you with this look of like, "Hey, dumbass,
Yeah.
um, you
Doctors
ruined that."
too. Mhm.
And so we try not to be that as nursing instructors, right? Like I know that my students are going to do stupid things like because they're young. They don't know this role. So I think that that's such a huge point is that people need to be given the opportunity to feel new. It's okay for
Mhm.
them to be new. It's okay for them to not know everything. So, for my seasoned nurses out there, don't be a dick.
Yeah.
Like,
Just
come on,
don't.
just
This
be
whole
nice.
idea of eat your young,
Yeah.
ridiculous. Stop
Well, so
doing
that's
it.
the problem, right? Is that like we act that way, like, oh well, I need to initiate them or whatever. Like, what is this hazing? Like bullying bullshit. Like we
Yeah,
act that way, and then we're like, why is there a nursing shortage? Well, sorry,
because you're
Susan.
being
Maybe don't be
mean.
such a raging biatch.
Right.
Just
Right.
saying. I just feel like that we should be raising these young nurses up to like be successful. And so part of that is teaching them things that sure, you might think that they should already know it coming out of nursing school, but they don't. Remember back to what it felt like when you had 53 exams in the course of a year. Like it's just a lot. So um try to
Yeah.
be kind.
Just give people grace in general. In general, just stop being mean. Just give everybody grace, right? Give people the ability to have a bad day,
For
right?
real. Well, a lot of times we work in facilities that are 24 hours a day. And so sometimes it's like, well, they didn't do this task.
And it's
Okay,
always
what did the
something
rest of their shift look
menial.
like? Yeah,
Yeah.
like it's a 24-hour facility. I don't know about you, but new stuff is always happening when on my shifts. It's like there's always more stuff. that's going on. Like, do I want to leave it a mess for you? No. I would like everything to be done. I would like all of the
Mhm.
things in Epic to be green. I would like, you know what I'm saying? I would like
I
every
do.
task to be
Yeah.
complete. I would like every room to be clean from head to toe. I would like every line to be working, every patient to be changed, all the things. But, however many patients or residents we have, there is always more stuff going on.
Ways. You're
And
right.
you could have somebody who went into cath right before shift change. And if you give your CNA a hard time, be like, oh, they didn't take the trash out. Well, the nurse went in and cath 5 minutes before shift change to make sure the bladder was empty
Yeah.
and forgot to take the trash with them. Like, just give them the benefit of the doubt, empty the trash, and be cool, you know?
Right. Right. And I will tell you also, as an off-going nurse, that is the most aggravating thing. If I've had a bad if you see the crash cart outside one of my other rooms, don't ask me why the trash is not taken out, okay?
For real.
That's a
You gonna
that's a good
ask
way
me
to
for a
set
blanket
me
too?
off. Yeah. Why don't I go get your coffee made for you while I'm at it, you know?
I know it is. I don't know. I think that that's some of this nurse culture that I don't love. I do love being a nurse. I absolutely adore it. But there's some of this culture stuff where it's just like people just being catty to one another, and it just to me, I just don't understand that. And I try to teach my students like, hey, let's not be that way. Remember what it was like. Don't be the person
Mhm.
who's like, I don't want to have a student with me. I don't want to, help. Why wouldn't you want to help? These are going to be your peers. You can help
Right.
form them into something awesome, or you can be like totally against it. And then you're always the one complaining about how there's nobody to cover you when you go on vacation. It just doesn't make
Right.
sense.
And just I mean, nursing is so centered on teamwork, right? How many shifts have you had where you can't even get through your day, right, without your entire team there? Like, let's foster this environment where everyone just feels comfortable and feels safe and that's gonna ultimately benefit everyone. So
That was one of the things that I loved about working in the ER the most is the team nursing camaraderie was amazing. Like,
mhm,
I don't know, ER nurses are my people for sure, because it's just like everybody just fills in and makes stuff happen. But our ratios that we had were really great. So it was like you'd have a pod where there'd be a room of five, another room of five, or a room of four. One side is four, one side is five beds, and you'd have each side would have a nurse, and then they would have a float between the two. And it was amazing because if you had a critical patient, that float could either take the critical patient or you could take your critical patient and they would take the rest of your patients while you're dealing with it. And
right.
it really just made for great camaraderie. And then also they had like it was like the best break system I've ever experienced because we were the busiest ER in Idaho. They'd be like, "Hey, you're gonna have a morning lunch break, and you're also gonna have an evening lunch break. You got two 30-minute
Well,
lunch breaks."
that's amazing.
And it was
Was it
incredible. And
Meridian?
you actually got to like put your phone down and not be doing stuff because you had somebody who is dedicated to take your patients during that time. And then
Yeah.
like as the day got busier, they add more staff. So you'd have like not only your float between your two pods, but you would also have like a department float who could go around and help take a critical patient or a trauma or
Oh.
whatever. And it was just like the greatest staffing ratios ever.
Oh,
And
yes, the resource nurses too,
yeah, we had, well,
the
and that's the thing. You had a
best.
hospital resource nurse, you had, different, like, we had crisis nurse who could come and help.
Yeah,
It
I would
was
always round
fantastic.
on the ED.
Yeah, absolutely fantastic way to staff things, in my opinion. I think that, like, if other departments could get that down, the way of like, hey, we work to help each other, and it's like, I feel like sometimes people just are so like, this is my patient, don't touch my patient, and I'm like, well, real, why?
I mean,
I know
I kind of
ICU nurses,
understand
y'all are
that
different.
because
You're like, don't touch
there's
my patient. That's
yeah, it's
mine.
a very different idea of teamwork, but when it works, man, it works. But yeah,
But that's why
don't
you got
touch
to
my
have
pump.
qualified people you trust, right? I mean, that's why you got to
Right,
train them
yes,
because they can either be a second set of hands for you or they can be somebody who's in your way that you don't trust.
right, and then you're coming into shift, and it's just setting, like, this entire mood of your shift, like, "Ah, man," so we've got a long way to go, but I really like the idea of having like a hand in teaching this philosophy, to future
Yeah.
nurses. I think that's
Well,
a
and
really
that's one
cool
of the great things I
opportunity.
like about like our simulations. We kind of help push that concept of team nursing at a really
Mhm.
early stage of like, hey, this person, this patient doesn't just belong to you,
Right.
right? Where do we get this like ownership of like they are mine? Back off. It's like, no, this is a patient of our facility. Let's all take care of them and do a really great job. But I think ownership is also a good thing over it's like, okay, I got to own the tasks. I got to own the things to make sure that they have a good experience, make sure that they have a good
Yeah,
outcome.
for sure.
So it's definitely a balance.
Yeah.
So, what are some other clinical pearls that you learned the hard way?
So one of them that kind of comes right to mind, right, is your drip chamber. So when you're hanging like that secondary line, whether it's an antibiotic or electrolytes, I mean, really, honestly,
Sure.
whatever it is, um, when you fill up that chamber, don't fill it up all the way, right?
You got to be able to see it
Um,
dripping.
you have to be able to see it dripping because when you walk into a room and you're like looking at your antibiotic and it should be done and it's not because it was clamped or and you didn't know that, right? Because your chamber's filled up all the way and so you can't see the drip. So I remember that being one, like when I first became a nurse, being kind of a big thing is like just filling the drip chamber up half away, making sure it's dripping, right? Before I walk away. And because it does happen, right? It always happens where you'll be busy and the one time you don't check that it's dripping is going to be the time that you throw off an entire antibiotic schedule, and that just doesn't feel good, to be on the opposite
Or
side
it's
of
wide
that.
open and you've realized that you forgot to plug it into the patient and then your
It's-
antibiotic is on the floor.
so actually this didn't happen to me, but this did when we were traveling, and I am not going to say which hospital, but we did have a nurse who had actually Y-sided under the pump and couldn't figure out why her antibiotic was just, like, running, and
Yeah,
it
that's
was
no good.
because yeah, it was because it was Y-sided under the pump, so your drip chamber will tell you a lot of things.
Yes.
Um
It does, and I think that a lot of times people kind of gloss over that because we have pumps that are smart and they can, if
Mhm,
you hook up a secondary line, you don't necessarily have to have them ordered, you know, as far as higher and lower. If they're going through a pump, they still give you that little piece of plastic to hook it up so that you can do that. And those are really set for gravity, not necessarily for the pump. And
mhm,
so sometimes people think that, oh, well, it's fine because it's got a pump. But if you Y-side in down below, that is not actually going through the pump. That's only going by gravity, and your other infusion is pushing it through,
mhm,
or your other infusion is stopping completely because it's flowing so fast, and then you're giving an antibiotic super fast. And guess what? You just gave your patient red man syndrome with their Vanco, or
and now you
you,
have a whole 'nother issue on your
yes,
hand. Not to mention a medication error, kind of going back to, like, the idea that the most dangerous mistakes, right, happen with these fundamental skills. Verifying your pumps dripping correctly, that it's hooked up correctly. Technology only works, right, if you utilize it correctly.
yes.
So we
Well, and how many
we
times do you think people make med errors that they don't even realize they made? Like they go about their business not even knowing that, hey, I made a
yes.
med error because I charted it correctly. But
Mhm.
that doesn't mean that I was procedurally correct, right?
One time I did get a call. I don't think I was crisis because this hospital was really, really small. So it was, we didn't have like a set crisis nurse. So if you were charging, right, in the ICU, you were kind of the one who would respond to these calls. But a really good example of that was I did get a call one time from one of the nurses on the tele floor because her patient had come in for chest pain, right? So they were giving nitro paste. And for those who don't know, right, nitro paste, nitroglycerin, it's a vasodilator, so it helps with chest pain. Um, if it's due to that lack of blood flow, right? If it's due to ischemia. So when you give this, it comes in, it kind of like a little ketchup packet is almost what it looks like. And there's like this little piece of paper that you squeeze it out and it helps you dose. Um, and so she gives us a call. She's like, hey, this patient came in for chest pain. We've been giving the nitro paste, but his blood pressure is really, really low now. So I was like, okay, well, I'm gonna come down there, but go ahead and take off the paper because normally when you give this, I'm sure you've given this a million and one times, Nick. You just kind of place it like right on their chest. So I was like, well, I'll come down, I'll take a look, but go ahead and remove that paper, right, and just kind of wipe off the nitro paste. And she goes, what do you mean? And I was like, what do you
Oh
mean? What do
no.
I mean? And she's like, "Well, it's a paste. I rubbed it in."
Oh.
And so I was like, "Okay, well, so there's really nothing we can do besides like wait it out. You're
Put
gonna
them
have to
on
call the
pressers.
doctor." I mean, it wasn't like scary low, thankfully. It was kind of one of those calls where I know I know people get so upset when we would ask them this because so it almost became like a joke when I was crisis nursing, where I would ask like, "Well, what's the map? Is it low or is the map just low? Or is the map like okay or is the map low?" And so he was okay. Thankfully, nothing happened to the patient. I mean, he had a wicked headache, right?
Oh yeah.
Um, but yeah, so when she looked at it, she's giving the right dose because these little packets are typically the dose that you would give. So with her, like as far as she knew, she did everything right, and she did do the right thing,
Sure.
calling someone to come and help and put eyes on this patient, but um giving this medication correctly and just kind of being aware of how we give it and familiar with the medication, right, that you're giving, could have saved her and, funny enough, the patient a
Yeah,
headache.
nitro paste is awesome because when I apply nitro paste and I put it on that thing, it doesn't all absorb immediately, right? And that's the great
Mm-hmm.
part about it is that because it's on the paper and I put it on their chest and it's not absorbed, I put a tegaderm over the top of it. And then if they start to be symptomatic, I can remove it. Whereas if I take a sublingual nitro, you can't take that away. If I
Mm-hmm.
give an IM injection or IV injection, I can't take it away. But with the nitro paste, I can get the effects of it, the vasodilation, but I can also remove it if the effects are too much, right?
Right.
So that's the reason why they often go with paste. And so, um, yeah, I mean, this is a thing where technically, did the nurse make a med error? No, but the standard of practice says do it with the paper, do it with a tegaderm, so that way I can take it off and be able to take the medication away if I need to, if the symptoms are too much, because it is a vasodilator, so it's going to cause that blood pressure to reduce. Obviously, if it's not cardiac in origin, and sometimes even if it is, they're going to get that severe headache, right? Because
Yeah.
it's vasodilating all those vessels, not just the coronary vessels.
Yeah. You too. Funny enough, if you accidentally get it on your hands or on your skin,
Yes. Wear your gloves.
wear your gloves.
Oh my gosh. I hate seeing people tear the finger off of their glove when they go to start an IV. I don't know. We just mentioned gloves, and it just made me think of this. So like we've all seen the TikTok guys, doctors being like, -1, no gloves. It bothers me so much when people tear their finger off. I'm
Yeah.
like, you can palpate a vein through the gloves. If I see my students doing this, I am livid. I am like, no, 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 no,
Yeah.
no, no. You did not learn this crap from me. Wear
If you
tighter
can't palpate
gloves.
it with the glove, you're not going to be able to palpate it without the glove. Like you're not wearing a mitten, okay? You're wearing a nitrile glove. Like
Let's be
it's really
honest.
okay.
If you tear the finger off of your glove
Oh my
when you're
god.
palpating a vein, you also don't believe in birth control.
Oh my gosh.
And your
I
screen protector on your phone is probably non existent. You don't use a hard case for your phone. You are a liability.
liability to to the healthcare and to just the public in general.
Yes, public menace number one.
It's so funny that you say that because I had like my first job, right, in the medical field was I actually worked in a lab and I was a phlebotomist. And dude, I thought that that was kind of the standard because so many people did it, right? Because like when you're drawing 50, 60 patients a day, um, and you would see these like more advanced phlebotomists, right? The people who have drawn blood for 20, 30 years. And they always did that. And so I remember being, early 20s, like first big girl job, other than that, I just worked kind of like part time at other places, but this was like my full time first healthcare. Like I knew I was going to start nursing school. I actually thought that was kind of the standard. So I will tell you, I did do that. I don't do it
No, and
anymore,
I
but I
think that there
did.
are a lot of people who did that, and like,
Yeah.
or like they saw somebody do it, and they're like, "Oh, well, that's just normal," but it's not. It's bloodborne pathogens, people. Like, yeah,
Mm-hmm.
if you poke yourself with the needle, you're obviously going to have a needle stick injury, whether you have gloves or not. The gloves aren't there to protect you from the needle. The gloves are there to protect you from the blood that you're drawing. Because if you have any kind of micro abrasion or cut, if you're like me and you work on cars or something every once in a while and you beat your hands up and you get blood in there, guess what? You now have a bloodborne pathogen
Mm-hmm.
exposure, and that's dangerous, right? I don't want Hep C. I don't want HIV. I don't want Hep B. I don't want any of these things. And even though you can have all the immunizations against whatever is immunizable, some of
Mm-hmm.
them are not, right? And I don't really want
Yeah.
to have to need treatment for any of these things. So that's why we wear gloves. We wear gloves to protect ourselves. It's PPE. And yes, I am an ER nurse, and we don't always love PPE. We're kind of the worst about it. But I wearing gloves is it's such an easy intervention to protect
Yeah.
yourself.
Standard precautions for a very, very good reason.
Yes. I mean, I'll be honest with you. The things that I'm most worried about are bed bugs, scabies, lice, anything
Mm.
bug driven. And I am like ultra PPE, but I'm like, nah, you got COVID, whatever. Ah,
So
you got the
I'm
flu, whatever.
Yeah. So I'm also not a bed bug person. So I'm just curious. I'm curious. Bed bugs or scabies? You have to get one.
Oh, God. Hopefully, neither. It's a really challenging question because they're both disgusting and I don't like them. Um, but I would, gosh, mm, if I have to pick and I have to take one, I'm gonna say scabies because I feel like it's easier to get rid of over the long course. And bed bugs are expensive to get rid of. Like bed bug abatement is huge. You know, people can go for a really long period of time trying to get rid of them and they
Yeah.
struggle to get rid of them. So I would definitely say scabies. I know you can get rid of them a lot easier. Bed
Yes.
bugs. I had this patient one time that was bed bugs, and it was on her chart. And I asked her, I'm like, "So have you had bed bug abatement? It's been a while since you've been here." And she
Hmm.
goes, "Oh, I didn't bring them with me." I'm like, "Excuse me?"
Oh
She's like,
my
"I didn't bring them with
God.
me." And then a few minutes later, I see a bug run across her body, and I'm like, "Oh my God!" Like, and the rest of your day, you're just like itchy, and it's terrible. And you're like, I need to like bleach my whole body or
Yeah.
something. Like,
Ew. I okay, so because like all nurses have their thing, right? That they don't like. Mine are like the creepy crawlies. I can do stool, I can do urine, I can do MSA, all the things. I'm not a bed bug person. Honestly, it wouldn't really bother me because I would go on a vacation with my cats and just like set my house on fire,
yeah, there you go.
you know? But I remember one time Ernesto like had a patient that had previously had bed bugs, right? Like they had come in, they had done their thing with the room, labeled them clear. I made him throw his shoes away. So I
Bummer.
just like that was kind of a running joke at the hospital that we were at was that because like I wouldn't even let him come into the car with his shoes. I was like, you need to call, you need to get different scrubs, please. Like,
They're
throw
so
your shoes
gross.
away. They're so gross, dude. Like, and I
And no
also
shade to
remember,
anybody who's ever had bed bugs and had to have bed bug abatement. Like
yeah,
I just, it doesn't mean you're a gross person. The bugs are gross.
no, they don't, because like you don't have to be dirty to get them, right? Like
Right.
they're a very opportunistic little bug, and they're, I mean, hotels, 5-star hotels get
Yeah.
them, right? But it just, oh, they give me the heebie-jeebies.
Yeah, I think it's one of those things where it's like once you've seen them, you're just kind of, and the bites look terrible, you know.
Yeah, and they're
Um,
uncomfortable.
it's super uncomfortable. Scabies is super uncomfortable though too. So like, I don't wish that on anybody,
Mm-mm.
except maybe if you're in the Epstein files, you can go ahead and get scabies and bed bugs at the same
Wow, didn't think we'd get to that topic first episode.
time. I'm
Holy
just
cow.
saying, like, if you diddle children, you go right ahead and get scabies and bed bugs. I wish those on you.
That's really nice, actually, as an outcome for that.
Oh no, I wish for worse things too, but we'll just leave that for
We'll
another day.
save that for a later episode.
I man,
uh,
no,
anyway,
I just feel like it's one of those things where if you have a patient with them, you feel itchy all day,
mm-hmm,
and
I
like
know.
even if nothing has happened, but people will put on the whole spacesuit, man, going into those rooms, and like other things they don't care. Yeah.
Nope.
But it's also funny though too because I feel like once you have that in your chart, I think that anytime somebody's been put on isolation for something that healthcare providers are kind of timid about, it's to the detriment of the patient, right? So bed bugs is one of them. Like if you had bed bugs, people are acting like they're less inclined to go and suit up and go in the room. And so then that means the patient actually gets worse care. And so this is a tough thing. I also,
Mm-hmm,
it's true of like when we know that a patient has C. diff, like people are like less in the room than they normally would be because of that. And that's to the detriment of the patient. So, like, we have PPE for a reason. Put the PPE on. I know it's a pain. You want to try to group cares, but at the same time, don't neglect your patient just because they
right.
have something communicable. Like, we got to still take great care of them.
Yeah, they still deserve that.
Yeah, and like patients with latent TB, right? It's not active. They don't have active TB, but sometimes there's this knowledge gap about precautions where it's like, well, we put them on precautions and they have latent TB, so they're not giving it to you. It's not communicable. They don't need to be
Right.
on precautions if it's latent. But sometimes it takes a while into their stay before that gets flagged appropriately and staff actually takes care of it. So I just feel like it's
Mm-hmm.
an opportunity for us to do better.
Yeah, I agree with that. And I mean, the important thing is that you're allowed to have these feelings, right? Like you can not like something, and that's totally fine, right? But when it starts to kind of overflow into your patient care, that's when it becomes a problem.
Exactly. And I think that like you talk about like preferences and things like that, sometimes our patients, they come from all different backgrounds, right? And we don't necessarily see eye to eye on stuff, but I don't care if I don't see eye to eye with my patients. I'm still going to advocate for the best care for them. I'm
Mhm.
still going to advocate for the best course of treatment for them. One of the things um, I might have a patient who has a different gender identity, or I might have something that maybe I don't understand as well. And that
Right.
doesn't mean that I'm not going to advocate on their behalf. It doesn't mean that I'm not going to try to get them what they're asking for, even if it goes outside of what I would do for myself or my family. And I think that that's a really important delineation that we make in nursing, that we don't have the opportunity to judge people anymore. I remember my pharmacology instructor in school. Her name's Amanda Dozier. She's a nurse practitioner. She's amazing. And one of the things that she always talked about, I'll never forget the story that she told of like taking care of this homeless man and like helping him with a bed bath. And she's like, he was so grateful like the whole time that
Mhm.
like I'm giving him a bed bath. And she's like, and it wasn't weird or awkward or anything, but she's like, I know some people will like shy away from these things. They're like, oh, I can't believe this guy doesn't take care of himself, or I can't believe that he has this happen in his life and that he's going through this. And it's like we almost take the humanity away from this person. And she talked
Mhm.
about and really gave this passionate, convicted speech about this of like, you're a nurse now. you don't get to judge people like you once did. And it was so powerful for me because I'm like, man, I can be a judgmental asshole like really, really easily. Like I can default to that super easy. And so I try to remind myself that people end up in the situations that they end up in because of choices, but also just because of misfortune.
Mhm.
And so it's really important to me to just remember that like no matter why they came into the situation that they're in, it's my responsibility to help care for them. It's my responsibility to do a great job for them. And it's my responsibility to advocate for them, even if there are things that I don't agree with their decisions that got them there. It's how do I help them today? How do I help them where they're at? And like to me, that's the powerful thing about nursing is like when we can do that,
Mhm.
it's just really awesome.
Yeah, it is really awesome, especially because I don't and I'm sure you've felt this too. Sometimes those people that you just take that second to, like, give them the care that they've had, like, that they haven't had, right, while they've been in the hospital. Sometimes they turn out to be the nicest people,
They
and
do. And it helps
that
grow us, you know?
yeah. Yeah, because I mean, when you become a nurse, like, you're just exposed to so much more, right? Like, you can always think that you've seen everything, and even now, like, I'm still learning things, right? Like, things still happen that I've never had any kind of exposure to, and so it it really does help turn you into, if you use that as an opportunity to learn empathy and to learn, you know, how to care for someone at their actual lowest point, then it really helps you become not only just like a well-rounded nurse, but like a well-rounded person.
Yeah. It's like this is we're growing you to be the best version of yourself. And
Mhm.
nursing kind of does that because it makes you see people in a different light. Now, obviously, can we also get jaded? For sure. But I think it's really important to like counteract that of like you can get jaded and frustrated about different stuff, but like I would encourage you if you find yourself in that space, you don't necessarily need to take a break from nursing, but you do need to take a look inside of like what's going on in you that's making me not care about people like I once did.
Mhm.
I don't know. I think people are worthy of being cared for. I think people are worthy of our attention and are making sure that we are mindful of what we're doing for them and what does their case actually need. And like so many times I see stuff just get blown off by people where they're like, well, it's not my problem. That's not my job. Um, in the ER, I remember having a conversation with one nurse leader at one point, and she's like, you don't need to be doing this case management stuff like we're in the ER. And I'm like,
Mhm.
well, we don't have a case manager here. So if I do this, I stop them from needing to come back. Right.
Right.
If I don't do it, they have to come back. Like, well, if we're just looking at it from the money side of it, the money side of it would say, well, it's another ER visit. But from the humanity side of it, I'm like, do you know how much money it costs to go to the ER? Like,
Yeah, and people are
it
already
costs a lot of
stressing when
money.
they're, like, making that decision, you know?
Yeah, they do. And like, why are we stressing about? We shouldn't have to stress about that. You should be able to go to the ER if you need to go to the ER. You should be able to go to your doctor if you need to go to your doctor.
Mhm.
And so, like, for me, I want to be the healthcare provider that's like, hey, you need this. This is the right thing. Like, let me put you in touch with this. And maybe it's a phone call, whatever. Maybe it means that you have a 20-minute longer length of stay. That's worth it to me
Mhm.
because if it stops you from needing to come back in 3 days, like, I just think that that's such a BS way to care for people.
Yeah, I
Like,
agree.
I don't know. I've just had too many experiences with healthcare on the receiving end of it to where it was like, wow, if you had made a phone call, I could have not had to come back 2 times. But nobody wants to do it because it's nobody's problem. And I always think about it this way: if it's nobody's problem, or if it's everybody's problem, it's nobody's problem, right? So if you like, it's really important. Like if you're charging or whatever to like assign patients out to people, you can't just be like it's everybody's patient. We're going to group think everything because somebody has to take accountability.
Yeah, you have to
But
have a
like at the same
primary.
time,
Mhm.
you can say, "Oh, well, that's not my job. I don't need to make that phone call. I don't need to set them up with that durable medical equipment." But like you do, like if you don't do that, they're going to be back, or they're going to get worse, or they're not going to make it, right? And like
Right.
the stuff we're dealing with is people's lives. It's kind of a big deal. All right, everybody. So this is the end of our first episode today. There's so many more things that we want to talk about, so many more things that we want to get to. Uh, First year nursing mistakes, IV skills, time management, charting mistakes. We're going to talk through tons of stories. We got more episodes coming at you. So if there's something that you want to hear about from us, please send us a message on social media. Let us know what you're thinking. Let us know what you want to hear, because we want to address those things, because this is really a podcast for you, aimed at helping you resuscitate your nursing education, aimed at growing you in your nursing career and in this profession that's so great. And we just love talking about nursing, and there's going to be a lot of great topics ahead. Make sure you like and subscribe and share. It's only going to grow. It's only going to get better from here. Thanks so much.
Thanks, guys.